It's November 3rd, and this is our October meeting of the minds. It's a few days late, but I just wanted to go ahead and make this quick video and get it posted on our page. I'm in the process of making a YouTube page for us as well. I know that some people don't have access to Facebook, so I'm going to put all these videos up there also. This month, I thought we could do something that's a little out of my wheelhouse in particular, but I did a little bit of research and just kind of found some good pointers that I thought would be helpful to know, since we do get these patients a lot. So it's over diffuse axonal injury, which is a type of traumatic brain injury that we see a lot, especially in the trauma ICU. So just bear with me. I'm going to do the best that I can. I've pulled a lot of this information from good sources and articles, which I've left the links to on each of the slides. So it's a little wordy, but I'm going to do my best to get through it and still make it interesting. So what is DAI? I'm kind of just going to read the little bits that I've put on here. But again, I've attached the links for all of the articles that are much more in-depth than what I kind of filtered out of them. So it's a form of traumatic brain injury. I didn't really go much into the other type of traumatic brain injury, which is a focal traumatic brain injury. We're going to focus more on diffuse. But it happens typically when the brain rapidly shifts inside the skull and an injury is occurring. So the long connecting fibers of the brain, called axons, are sheared, and the brain rapidly accelerates and decelerates inside the skull. So I'm sure we all learned in nursing school about coup contra coup injuries. So it's kind of when the head thrashes forward and backwards, the brain moves inside the skull cavity, thrashing forward and backwards as well. So that's why this is a common injury in patients who are in car accidents or quickly accelerating, decelerating traumas. So I have this little picture here that I thought kind of explained it nicely. So you can see the axon in the brain, and basically it just shears kind of in some region of the axon, which, let me jump back. This picture I thought was really helpful as well. So if you're looking at the skin, it kind of shows you where the axons are in here, and the tissue. And basically the tissue is being pulled in two different directions, which is what causes the shearing force on the axon and kind of causes it to twist and possibly break. And then although it's coined as diffuse, the pattern of axonal damage in the white matter of the brain is accurately described as multifocal versus diffuse. I thought that was really interesting. So the article I read talked a lot about focal versus diffuse brain injuries. And even though we call this a diffuse axonal injury, it's not really everywhere scattered all across the brain. It's more multifocal because it can just hit different parts of the brain in specific areas versus the entire brain being affected by it. So think of it more as multifocal rather than diffuse. This picture here is kind of that coup contra coup I was talking about. So your head hits, the steering wheel or the windshield or a wall or whatever stops, your momentum. And then the brain can kind of still continue to move within that skull cavity, and that's what causes the shearing of those axons. I thought this was the best picture that I found, which is why I kind of put it on the biomechanics of DAI slide. But you can just see here, it gets very in-depth as far as the white matter and the gray matter, but we're not going to go into that much just because that's not really something we need to know necessarily. But it's just when the white matter and the gray matter kind of shear apart from the forces being placed on the brain coming from opposite directions. So the mechanical forces associated with DAI occurring is the rotational acceleration of the brain, which results from unrestricted head movement right after the injury occurs. I know that's kind of a mouthful, but if you read it a few times and kind of break it down, it does make a lot more sense. The inertial loading, so just kind of the force that's loaded to the brain, is what induces the shear. So that's what causes the shearing of the axons. It also can cause tensile and compressive strains within the tissue of the brain, and that's what gives us DAI. Under a normal everyday activity, the brain tissue is pretty compliant to stretching and it recovers quite easily. But in contrast, when you have some kind of severe circumstance, like a very quick accelerating, decelerating force, like a car accident, then the brain tissues get really stiff, which essentially make them more brittle. So, I mean, you see this in patients that get whiplash. So when you are really tense, it makes your tissue more likely to undergo damage if you're in an accident or something like that. I think that's why there's been other studies done. A lot of times when patients are under the influence of drugs or alcohol, that's why a lot of times their injuries aren't always necessarily as severe, because when they hit or at the point of impact, they're a lot more relaxed than, somebody who's conscious and can kind of tense and prepare for the accident that they can see coming. We all know what the Glasgow Coma Scale is. We use it 4 times or 3 to 4 times a shift, sometimes more. But I thought this was pretty interesting. It's just a little tidbit about where they categorize different levels of traumatic brain injuries. So your patients who have a higher GCS are going to be classified as mild. Kind of somewhere in the middle, they're going to be considered a moderate traumatic brain injury, where when you hit below 8, they're classified as severe traumatic brain injuries. And in our facility, we typically start intubating patients if their GCS is less than 8. If they come into room 9 or the ER and they don't have a GCS higher than 8, then they're usually intubated. It's all circumstantial in the case, of course, but I thought that was pretty interesting since it's something we're so familiar with. I didn't really know that there was a categorization of mild to severe traumatic brain injuries based on the Glasgow Coma Scale. Diagnosing, this is not something we do. I just thought this was nice to know as far as information goes. We, as clinical nurses, do not diagnose patients. It's not within our scope of practice, just to make this very clear. It is the physician's scope of practice to do a diagnostic exam or diagnose the patient's condition. But obviously, we most of us know through our experience, we scan our patients to find out if they have DAI. So clinically, it's pretty difficult. I have done here. It's very difficult to detect and poorly defined as a clinical syndrome. So there's not a test that we can do at the bedside typically that diagnostically tells us, yes, this patient has a diffuse axonal injury. We have to scan them. But usually we can kind of tell if our patient's GCS is low and we've ruled out other types of brain injuries such as bleeds or, high intracranial pressure or stuff like that, and they're still acting like a head patient, it might be a good idea to just suggest to the physician or ask the physician, have we considered DAI? Because I feel like a lot of times we don't catch DAI until it's a little bit later in the patient's stay after we've ruled out several other things. But just don't forget about it. So typically we, sorry, that was my dog. Typically, we don't do CT scans just because they have a low yield in detecting diffuse axonal injury, so MRI is kind of the gold standard for how we're going to diagnose patients who have DAI. In clinical practice, a diagnosis of DAI is made by implementing clinical information and radiographic findings. So you assess the patient, and if you think they fit the symptoms of having DAI, then you scan them, and that can be your confirmation. And then also, I thought this was something that was good to consider. Understanding the mechanism of head injury really can facilitate a differential diagnosis. So if you know the patient was in a high-speed accident, or they had that coup contre coup injury where their head was thrashed back and forth for some reason, if maybe they were assaulted, then that's really important to kind of early diagnosing the patient might have DAI and getting that scan appropriately. And then lastly, just treatment. So unfortunately, there's really not a ton we can do for these patients acutely except manage their symptoms. So treatment of patients with diffuse axonal injury is really geared more towards prevention of secondary injuries and facilitating rehabilitation. It appears to be the secondary injuries that lead to increased mortality. So these patients that are in the hospital and on the ventilator for several days, maybe getting pneumonia or getting urinary tract infections or septic infections that lead to their mortality and an increased morbidity. So in head patients specifically, it can include hypoxia with coexistence of hypotension. So just making sure your patients have a good cerebral perfusion pressure, a low intracranial pressure. We're reducing or making sure that they don't have a lot of edema or swelling on the brain. So we can make sure that tissue stays intact and functional for later in their recovery process once they get to rehabilitation. So therefore, prompt care to avoid hypotension, hypoxia, cerebral edema, and elevated intracranial pressure is advised. I mean, we all know how to manage a standard head patient. You just want to make sure they don't have elevated ICPs, they have a good blood pressure so they're perfusing their brain tissue again, and that they don't have any swelling on the brain, which is more up to the physician to kind of dictate whether or not any decompressive surgery or drains need to be placed to avoid that. This was just a quick little slideshow. Like I said, this isn't really my area of expertise, but I thought it was something interesting that we could all use just a little bit more knowledge on, because it's kind of a vague topic that we don't really talk about or learn a lot about in nursing school, or in our ICU classes. So I thought we'd just hit it a little bit harder. If you guys have any questions, please feel free to text me, or you can comment on the video, and I'd be happy to figure out anything that I don't know. Thanks for listening.